Thank you for your attention. I'm using Mark's slides, so if I slip up a little, I apologize. It wasn't really enough time to come up with my own talk, and since he'd already uploaded them, I said, what the heck, let's do it. These are Mark's disclosures. I also have no disclosures. The prevalence of adolescent weight loss surgery in the U.S. Has not significantly increased over the last 10 years. And actually, I have prevalence data being presented in another IPEG session right now that shows that it really hasn't increased significantly. There are about 1,500 cases a year being performed now up through, our study looked through 2015. The contemporary evidence, again, is about, perhaps maybe 15,000 cases a year. 1,500 cases a year. There are 3 operations that are primarily done in adolescents: the gastric bypass, the sleeve gastrectomy, and the adjustable gastric band. The number of these cases being done, and again, our study actually supports this as well, it has changed significantly in the last 10 years, with a decrease in the number of gastric bypasses, a significant decrease in the number of adjustable gastric bands, and an increase in the number of sleeve gastrectomies being done in adolescents. The biliopancreatic diversion numbers have not significantly changed. And you can see that decrease and increase is fairly significant, where almost 70% of operations are being done in, and this is adult data, but again, the adolescent data that we're presenting right now in another room shows the same thing. The estimate of bariatric surgery numbers that come from BOLD, again, basically show that the same data, again, there's more sleeves being done, fewer bypasses, and almost very few bands these days. And this is, again, the surgical type of procedure. This looks at the teen labs data, and you can see that in teen labs, as they were collecting data, you had a significant drop in the number of bypasses, an increase in the number of sleeves, and the number of bands is actually quite small in this data. So what are the advantages and disadvantages of the Roux-en-Y gastric bypass? This is actually from the ASMBS website. The advantages are significant long-term weight loss, 60 to 80% of excess body weight for a gastric bypass. It restricts the amount of food. It leads to conditions that increase energy expenditure, in other words, hormonal changes. It produces favorable changes in those hormones that reduce appetite and enhance satiety. And typical maintenance weight is about a loss of about 50% of excess body weight loss at 10 and 20 years. If you look at the disadvantages, it's technically more difficult to perform than the sleeve gastrectomy or the adjustable gastric band. It does have higher complication rates. It has higher reoperation rates. It can lead to long-term vitamin and mineral deficiencies, especially the B vitamins, iron, calcium, and folate. It has a longer hospital stay than the adjustable gastric band, although it's about equal to the sleeve these days. It requires adherence to dietary recommendations and lifelong mineral supplements and follow-up compliance. Patients who have this operation really do need to follow up annually for vitamin level checks. And we have data, though, that looks at, there's 3 major studies out, both Teen Labs, FABS, and AMOS, that Dr. Inge will be presenting after me, that shows the outcomes from this operation. Right now, we give this operation a green light. This is an operation that is reasonable in adolescents and should be used in the appropriate adolescent. There's long-term outcomes that, again, Dr. Inge is going to expound on later. But basically, what we found in adolescents is significant improvement in diabetes, prediabetes, dyslipidemia, blood pressure, and abnormal kidney function, similar to what we see in adults, but actually even better in adolescents. The advantages to the sleeve gastrectomy is that it restricts the amount of food that the stomach can hold. It induces rapid and significant weight loss. similar to the gastric bypass. And in adolescents, in the teen lab study, the weight loss was almost identical. There was no statistical difference. It requires no foreign body like the adjustable gastric band and no rerouting of the food stream. And there's relatively short hospital stay. Some patients with a sleeve may go home sooner than a patient with a bypass, and it causes favorable changes to the gut hormones as well, reducing appetite and improving satiety. The disadvantages is it is truly a non-reversible operation. As I tell the kids, the stomach goes in the bucket. It's gone. We're not going to be able to replace it. It has the potential for long-term vitamin deficiencies, and it has a higher complication rate than the adjustable gastric band. What isn't here, and what I think is actually a primary complication of this operation, is gastroesophageal reflux, and we're actually going to address that in the final talk today. There are several prospective studies. The largest one is by Al-Qahtani, which is in the Middle East, but they all show positive results, and we give a green light to the vertical sleeve gastrectomy as an operation to be used in adolescents. The Al-Qahtani study basically shows excellent outcomes in terms of weight loss, percent change in BMI, and this is a 2-year follow-up showing a 35.9% change in mean BMI. And his results are significantly better than some of the other results that we've seen. The advantages of the gastric band. We give a red light to the gastric band, basically because of the long-term complications. Again, like Mary said, these are operations that have to last 60 years. And in adolescence, it's unclear whether a band is going to last 60 years. In fact, it's pretty clear that a band is not going to last 60 years, which requires a reoperation. So you can basically say that in an adolescent putting a band in, there is a 100% chance that that child is going to need another operation, 100%. So that's why we give it a red light. It does reduce the amount of stomach food in the stomach that the stomach can hold. It results in excess weight loss of approximately 40 to 50% in some patients. It again has very variable results. It involves no cutting of the stomach or rerouting. It's a shorter hospital stay. It is reversible, although I have, this says it on the ASMBS website, I really don't believe the band is reversible because it does cause scar tissue. And I have seen patients who have had erosions of band and really are not eligible for any other bariatric procedure. So it's not actually reversible in everybody. It has a low rate of postoperative complications early on, but a high rate later on. The disadvantages, again, are slower and less early weight loss. Excuse me. It requires a foreign device. It can possibly develop band slippage. There are mechanical problems with the band. It results in dilatation of the esophagus if it's tightened too tightly, and it ultimately results in encapsulation and unadjustability in the long run. And it has the highest rate of reoperation of any, like I said, any of the procedures. There are prospective randomized controlled trials in Australia. There are, but the band is still not FDA approved for under 18. And it was used only in study protocols. In some of the teen labs data does talk about their outcomes for the band, but they were very, very small numbers. If you look at the weight change in the gastric bypass, the vertical sleeve gastrectomy, and the band in the teen labs data, and again, there were very small numbers, you can see that the band patients did not lose significant weight compared to the sleeve or the bypass. So what about the duodenal switch? The results are greater in terms of weight loss with the duodenal switch, about 60 to 70% excess body weight loss at 5 years follow-up compared to the 50% we see with the other operations. It does allow patients to eat eventually fairly normal meals. It reduces absorption of fat by about 70%, which can be a problem in terms of fat-soluble vitamins, especially in a growing child who needs vitamin D and A, E, and K as well. It is the most effective against diabetes compared to the other operations, and so for long-standing diabetes in adult, it may be a very good operation, but again, in a growing child, it might not be your best choice. It has higher complication rates and mortality than the other 3 operations I just discussed. It requires a longer hospital stay, and it requires potential significant vitamin deficiencies, again, especially the fat-soluble vitamins. Compliance and follow-up visits are extremely important with this operation, and so I would say in the United States, where most of our patients are going to go away to college and be lost to follow-up, it is probably a very poor choice. There may be some countries where healthcare is more local, where it may be appropriate, but certainly in this country, it's a very poor choice. And again, it's not being done that much, and there are no good long-term studies to date looking at this operation in adolescents. So what's in the future? What's being tried out there? There are other operations being tried, and some of them are being tried in adolescents. Not as many in the United States as outside the United States, but certainly there are operations. Plication of the stomach is one of them. And I know this is being done in adolescents because I've had adolescents come to me and need reversal of this operation in order to perform an operation that was more routine and effective. Balloons are being used in adolescents. Again, I would argue that the long-term weight loss is what we're looking for in an adolescent, and a balloon is not a long-term solution to obesity yet. There may be modifications to it in the future that might help. There's also the intraluminal sleeve that, as far as I know, is not being used in adolescents currently, but might have a role in certain adolescents. And these operations, I would say, may have a role because they are reversible and endoscopic in patients who, for example, present with orthopedic complications and need rapid weight loss prior to an orthopedic procedure, or other things. So they shouldn't be excluded in adolescents, but we need to think about how we're using them. I don't think either of these offer a permanent solution to obesity for an adolescent, but they may offer a temporary solution to obesity for an adolescent who requires another intervention. I think that vagal stimulation is still very much up in the air. We don't know long-term what that's going to offer, but it may be a good option in the future. And all of these that are being used in adults, we would like to see studies being done in adolescents once they are proven safe and effective. We don't want necessarily to do the studies on the adolescents too prematurely, but we also don't want to deny the use of these procedures in adolescents where they may be needed. So, and what's going to come down the line after? Who knows? We could be doing any number of things. It's hard to know, but I'm not sure where the future will carry us. Adolescents represent a distinct population with unique considerations related to long-term outcomes. Metabolic bariatric surgery outcomes in adolescents are similar to that in adults. And there's a shift in procedural prevalence that has mirrored largely the adult population, a shift to the sleeve from the bypass and the band. And the current consensus is unable to identify the best operation for teens, just like we're unable to identify the best operation for adults. So it's sort of the same conundrum that we come to, is the sleeve better, is the bypass better? I don't think long-term we really know. And I think that, the one thing that you can tell an adolescent who's going to be undergoing an operation is you may need another operation in the future. Because I don't think any of us can guarantee that any of the operations we're doing today are the final answer for that adolescent. Eventually, comparative analysis will drive ongoing changes in current recommendations. And again, the more data we collect, it's wonderful that the MBSA-QIP is finally collecting data on adolescents. And I'm very hopeful that that data will give us more information. The Teen Lab study, the AMO study, all of these are ongoing and will hopefully give us more data as time goes by. Thank you. This is one of Mark's patients.
Thank you, Janey. That was great.